Wow, thank you so much. This has been an amazing conversation. I really, really appreciate the dialogue. It's very, very exciting. And I can't tell you, there's so many conversations that I would love to dive into that happened this morning. But I'm really here to sort of bring the lens down a little bit. It's not quite at the ground level. We do have some people in the room who are at the ground level, and I'd like to acknowledge them. That's the folks from Momentum. And also other folks from the other initiative that are also here that are working with homeless every day. But really, I'm a big fan of Zoom lenses and really trying to figure out, are we talking at the micro, macro level, and making sure that we align our conversation. So what I'm going to do today is really talk to you about the project as it's evolving that relates to mental health and those with mental illness. But first, I really, really want to echo my thanks to the folks in Santa Clara County, because we have a very unique community, and particularly in government and in the nonprofit sector. I really want to thank the leaders of the county, and particularly Gary Graves, for being such a champion and really supporting good things to happen. And our Board of Supervisors that's very progressive, and I think also very courageous and willing to make change and take those steps. And to the partners that we have, from the nonprofits to the other institutions or the other social service agencies that we have that we work with, whether it's the city or other county departments or big nonprofits. We have a lot of great partners going on. I don't think that you can accomplish these kinds of initiatives unless you have the relationships in place that are really going to make that happen. And so we have great partners here. I also think that we have some of those qualities that that have been talked about in terms of leadership. I sort of look at it as though you need to have leadership. You have to have leaders step forward and say, we're going to go here. This is what we're going to do. They have to have the will, but they also have to have the courage, because the courage means, and as we've talked about, that you have to be willing to fail. And you have to be willing to say, yep, if this doesn't work, we're going to do something else. And there's a lot of courage in taking on the risk that we've talked about. And then finally, there's that great intellect that Gary talked about. And I think us being able to tap into the new thinking, the new intelligence, the new information that's coming forward, we just have to find people who are really there mining in new information for us, and they're bringing that great intellect to whatever we do. And then I think finally I want to say, in our field, we really are very focused on the recipients of care. In healthcare in general, the recipient of care, whether you want to call it the patient or the customer or the consumer, that really is what we're all about. And until we are able to get inside their world and their lives and what they want and are looking for, and we're really able to engage with them, we won't be successful. That couldn't be more important in my field in mental health. What I'm going to talk about really quickly is the what, the why, and the how. On the what side, we have a population out of our public mental health system. It's a very large system. It's about $330 million worth of services provided to about 25,000 people every year who are ill. They meet criteria as being seriously mentally ill, and it's all ages, from 0 to 100. And in that system, we have probably about 10% at any time. And actually, it's only about 500 to 700 people at any time who are in what we would call our 24-hour care system, which means institutions, whether it is an emergency room or a hospital bed or a locked skilled nursing facility bed, which we call IMDs, or supplemented residential programs. And that small percent is consuming a very large portion, about 25% of our budget. And we really have not made the kind of progress I think we've needed to make in terms of moving people out of institutions and into the community. So our challenge here in our initiative, and Barbara Aarons, she just passed away, she would love to have this initiative named after her, because she was a disruptive innovator. She probably wouldn't be able to work for the county right now in terms of how innovative she was. And she was my very first boss in the county. And she ran Barbara Aaron's Pavilion, psychiatrist, a wonderful psychiatrist. And so what we're really doing is zeroing in on those people who are spending time, not very brief, acute time in institutions, but they're spending multiple times and often for very long periods in institutions. So why are we doing that? And this is the deep end of our system, and I would say it's the public deep end of the system, and I would actually say that, in fact, the private deep end of the system is the public deep end of the system, because most insurance, most people who come into our system, they have exhausted their benefits, and they may have paid very dearly through their insurance or privately, but most of them have exhausted their personal resources, and they rely on the public system. So why are we doing this? Why are we focusing on this small cohort, if you will, in the public mental health system? We have launched in the last year or so a focus in our quality improvement effort in the mental health department. And one of the things that we've really sort of become very attached to is Deming's value chain reaction. And that's all related to us trying to have the best quality service, but also to be very business-minded and to really understand how are we as a business operating. And when we really sort of latched on to Deming's value chain, at the top of the chain, and the message was, if you're not focused on the value to the customer, you are going to fail. And it doesn't matter what your business is, truly, if you don't focus on the value to the customer, you are going to fail. And in this case, certainly the value to the customer is not only those that we serve, but it's society as well, because this is a social issue. If you think about institutionalization and how many people in our society are living in institutions, whatever kind you want to look at, incarceration, skilled nursing, mental health institutions, foster care institutions, institutions are not places for human beings to thrive. They just aren't. They never have been. And we are learning about that, but we're not learning fast enough. One of the things I really appreciated was a personal story, because I think unless, again, for the value to the customer, if we can't bring that home in our own life, we really are not going to have the kind of passion and commitment that we need to have. So I thought I would just tell you a brief little story. 100 years ago, actually, this year, right now, my grandmother was caring for a 6-month-old baby. That was my mom. And we don't really know what happened, but she had some sort of episode in her life. She was living in a very middle class, very educational environment, actually. Her husband, my grandfather, was a headmaster of a private school in Southern California. And she had some sort of an episode. It was diagnosed as melancholia, and it was probably postpartum depression. But what happened from then on was kind of a mystery. It's very vague, very hard to get any relatives to speak about it. All I know is that she died in Metropolitan State Hospital. We don't know where she's buried. We don't know really what happened, but she died in a state hospital. And that state hospital is still there, and 100 years is too long for too many people to be living their lives. We have to do something about it. I'm sorry to say that I don't think that my field has made the kind of progress in 100 years that we should have expected. And we need to do better. Right now, the state hospitals have emptied of the non-criminal mentally ill and filled with those who are involved in the criminal justice system. And actually, my fear is that they will be emptying with the criminally mentally ill, and they will be filling with the aged population, who is my demographic. And my demographic is moving quickly to not having the right solutions for it to care for us to age in place. So there's a lot of really good reasons as to why we need to do this and why we need to bring our intelligence and our creativity and the dollars that we're spending inefficiently, I believe, to this effort. So that really is the why of what we're doing. So how are we going to do it? We're focusing in on a population, and that population are those who are frequent users and long-term users of inpatient. Barbara Aaron's is the term we use, but we actually have contracted hospitals as well. So at any day of the week, we will have 75 to 100 people in an acute hospital. And we will also have another 30 people in an emergency room waiting to go into an acute hospital. Unfortunately, many of those will come back. Up to 1/4 of those will come back, and they will come back 3 times in a year, and they will spend many days in a hospital. And many days in the hospital will not be paid for by insurance, because the utilization management function comes in and says, this person does not meet medical necessity for this level of care. And so at any time, we have half of our inpatient beds filled with people who the psychiatric UR folks have come in and said the insurance won't pay for it. They're not deemed to need this level of care. So one of my big mantras over the years has been the data does not tell us that we need more hospital beds. It hasn't for about 20 years, because for 20 years we've had about 50% of the people that we serve needing and waiting for something different. But for some reason, we have not had the system in place that could accommodate what was needed by this group of folks. So that's really what we're going to zero in on. We're going to zero in on first looking at the data. And in this case, the data is not only quantitative data, it's data that we're pulling out of records, and it's data that we're pulling out of the system, but it's qualitative data too, because we know that the factors that are contributing to the situation in these individuals' lives are medical, they're behavioral, and they're social. And we will not really understand what is the antecedents and the precipitants of people coming into the hospital via crisis, because as Gary said, they come in the front door first in crisis, and then they move into a hospital bed as an acute patient, and then the crisis stabilizes, at least medically, from the perspective of the physicians who are treating them, and they're ready to go. And that's the point at which, and I really need to say, we have been working on this for years, and I think have the most innovative strategies in place in our county. And we still have not solved that problem. And I think we're ready for the problem, because we do have some strategies that have been put in place. The full service partnership, which is a wraparound model, and it really is an extension of what we learned with children, is if you individualize and wrap the proper service around people who have really complex conditions, then you will be able to create the ecology, the social ecology, and the kind of expertise that's needed to respond to the needs of those individuals. 2 minutes, and what we will be doing is zeroing in really on what the population is that we want to make available, and we will identify what the contract is and how we will procure that. For providers, we luckily do have providers in our system that are very experienced in serving the population. I think what really is going to be the true sort of test is, can you constellate around an individual? And by the way, I think this is true for all of us as we go into the deep end, no matter what our condition may be, whether it's age or a medical problem or a social problem. If we can constellate the expertise that is really going to be responsive to that person's needs, and whatever it is that, and we can really understand how the person has crises. Because I can tell you, of those 500 people, there are thousands more who have the same conditions. Many of them are employees in our system right now who have spent many years in institutions, and they are now peer support, case management professionals in our field. What is the difference, and how will we understand the difference between those who are thriving and those who aren't? And how do we tailor that around the unique circumstances of individuals? So that's our challenge. Hopefully I'll get to come back in a year or two And then by then I'll be babysitting the third sector's kids. No, just kidding, on a volunteer basis, because they're amazing. We'll be able to tell you about the great success that we've achieved. So thank you.